So Shannon, tell us what to do on this PARP after PARP issue.
Yeah, well, let
how-
me just comment first. I think that the addition of bevacizumab is exactly what I would have done. I definitely consider it with paclitaxel, but also use pegylated liposomal doxorubicin based on the recent paper that came out that showed that had a benefit over gemcitabine and carboplatin and bevacizumab. I think that, as far as re-resection is concerned, this patient had a multifocal recurrence, which even prior to Dr. Coleman's GOG-213 data, that pushed me away from the consideration of re-resection. With that being said, we're eagerly anticipating the results of Desktop 3, which are going to be presented at ASCO this year virtually. And so, I think that if there is a way to do better selection rather than just saying, say, somebody's a surgical candidate versus somebody, using kind of strict criteria to determine who might benefit from secondary cytoreduction, I would, I'll definitely consider that. But for her, it sounds like it was more of a multifocal. To your point, I think we don't know the answer for PARP after PARP. There are a number of really interesting studies that are ongoing that are looking at, can you just do PARP alone? The Oreo study, I think it's completely enrolled now. That study was in secondary maintenance. So they got secondary maintenance with olaparib and then ultimately progressed, got retreated with a paclitaxel or carboplatin-based chemotherapy, had another response to therapy, and then are randomized again to olaparib. That will be very informative. Again, not exactly informative to our patients that are going to be getting these PARP inhibitors up front, but will be very interesting to see if there's activity in that setting. But I am very interested in the combinations here. I think we have a number of really cool trials that are combining different, anti-angiogenics, immune oncology agents, other, tyrosine kinase inhibitors across a number of really cool survival pathways. That I think is going to be incredibly informative to see if you can overcome that so-called PARP resistance and really kind of go back to that well. So I think that there's a lot to be learned here now.
All right, great discussion. This is another one of those that we could just go for hours on in and of itself. So what does the NCCN tell us? Well, certainly we've hit on this. We could consider secondary cytoreductive surgery, GOG-213, as Tom mentioned. Did not show a benefit. I think Dr. Coleman has got some additional information that's going to be coming out soon on that topic. But we also await the German group's input as well, and that's going to be interesting to see. And if we have conflicting data, well, we can rationalize anything that we do at that point. But I agree with you on the multifocal recurrence aspect of this as well. I'd probably not re-resect in multifocal recurrence. So as far as chemotherapy goes, then in this case, certainly combination platinum-based chemotherapy is the preferred regimen, and then consideration of maintenance. And if the patient has been on carbotaxol Bev previously, then Bev is favored again. In a patient who has not, in other patients who have not been on Bev, then consider one of the three PARPs that are great options for us at this point.